So welcome to your assessment and management of the critical casualty. This is the second of 3 series of austere and operational environments for the critical casualty. I have no financial interest in relation to this presentation or conflict of interest. I don't own any stock in any equipment that we're going to be using. To assess the critical casualty, you need to have the importance of your own experience. So planning and training are 2 separate things, and you can have this knowledge in the hands, you can have this knowledge in the head. You need both to be a good critical care provider. We're going to talk about the importance of early identification of patients at risk and some warning signs that's going to tell you ahead of time that you're moving into a critical casualty. This person you're treating on a hotel bed in some place is no longer just a medical casualty. They have moved into the critical casualty. So we'll recognize early signs and symptoms of critical illness, and we'll discuss initial assessment and stabilization of the critical ill or injured patient. So a case study. Here is a 36-year-old man brought into your remote clinic after he was ejected from a vehicle in a rollover accident. It's about an hour from the time that the vehicle had a rollover to the time they walk through your tent door. So we are looking at basic observations, and CPRO is what we use for initial assessment. It's something that the four variables you can get very quickly with just a pulse oximeter. We'll talk about this. These 4 things, the CPRO, you need to get very, very quickly. If you don't have the 4 vital signs of CPRO by the time you're done with your breathing assessment, you're just not doing it correctly. You need to get this pretty quickly. So C in CPRO is capillary refill. I'm looking at 2 seconds or less for capillary refill. P is the pulse or heart rate. R is respiratory rate, and O is your oximetry. So CPRO, and all you need is a pulse ox to get it. Really, it's pretty easy to get. So this casualty has a CPRO he's got 3-second capillary refill. He's got 125 heart rate. He's got a respiratory rate of 39. And for some reason, he's able to get at least 93% on his pulse ox. So yeah, any red flags here? What we look for when we are doing our assessment is red flags. So anything more than 2 seconds of capillary refill is a red flag. Anything over 100 pulse rate is a red flag. Anything over 20 respiratory rate is a red flag. And anything below 94% oximetry is a red flag. So right off the bat, this guy has 4 red flags. We also have that's primary vital signs of CPRO, and we have the secondary vital signs, which are the 5 ones that take a little longer to get. So B, we use BEAST to remember. So B is blood pressure, E is your ECG, A is your alert status, S is your sugar levels or BM levels, and T is your temperature. So these 5 are pretty important as well, but you can get them once you get down to, so you got your C, A, B, C, D, E, and F. After you've done your E environment, F is full set of vitals. And that's when, by that time, you need to have your CPRO, which you've gotten in B or C, as well as your BEAST, which they'll take a little longer to get. So B is blood pressure is 90 over 50. So that's a red flag. Anything over or anything under 100. So your ECG, because its pulse rate is so high, even though it's a normal sinus rhythm, it's not normal. It's at fast. So we call it tachy sinus or sinus tachy. Alert status, we use GCS, but I like ANO times 4 better. So ANO is alert and oriented times 4. There's four questions you're asking the casualty: person, place, time, and event, and which of those 4 things they can remember is going to give them their alert status. The reason I like that better than GCS is you can get 5 different practitioners giving a GCS score, and you're going to get 5 different GCS scores. Now, granted, they're going to be 13, 14, 13, maybe a 12, 13. So they're going to be in the same category, but it's enough variable that, do I intubate somebody who has a 9, but I think is an 8? So there's something to think about. So we have a lot of red flags on this casualty, on this critical casualty. So we need to think about what do we suspect is going to be potential rapid deterioration. So any of these red flags could, so right now he's compensating. So his heart rate is way high. His BP is middle to low. So he's still technically compensating, but there's a potential for rapid deterioration. And we need to look at what vital signs we're looking for and other hemodynamic measurements so we can look for. And which aspects of the physical examination would you concentrate on initially? So and these are all questions I've got straight off of a critical care textbooks. This is why we're going through these. So this is why we differentiate between our primary and secondary vital signs. So CPRO is your primary vital sign, and that's something we're going to focus on first. And that's basically oximetry and how compensating this person is. If their capillary refill is starting to go up, and that's an early sign that there's a problem. BP is great, and I'm an avid fan of getting a BP. We'll talk about that. But it takes a while, and you can go 5 minutes working frantically on this critical casualty before you remember to get another blood pressure. But CPRO is something that you're going to monitor more often, and you're going to see a red flag pop up first in your CPRO than you are on your secondary vital signs, your blood pressure, your ECG, your alert status, your sugar, your temperature. Those take a while to move up or move down. Your CPRO doesn't. Your CPRO can change immediately. So this is why we focus on the primary vital sign over the secondary vital signs. And interventions we would perform to stabilize this patient. So he's compensating. He's got trauma. So he's probably losing blood in his pelvis or his chest or belly. We don't know. We can use our assessment system we talked about in the last class. We're going to get into it a bit more on what is wrong with this casualty. So he's bleeding out somewhere. We use our ultrasound. We use our hemodynamic parameters to find out where. And then if he's losing a fluid, that's the fluid we need to give back to him. If he's losing blood, we need to give back blood. So interventions we need to perform is giving blood or blood products if you have this available. If he's losing water from sweating or diarrhea, then he doesn't need blood. He's been losing water. We're not going to give him blood because he's not losing blood. So if he's losing water, we give him water. If he's losing blood, you want to give him blood. Investigation. So we need to look at his hemodynamic parameters. So yes, you can look at your CPRO and your primary vital signs. You can look at your secondary vital signs. But I want you guys to start thinking about some of the hemodynamic monitoring we can do with non-invasive skills to investigate a bit more on what's wrong with this casualty. And you got to think about austere location and how it affects your evaluation. Working as a critical care paramedic on an ambulance is different. I have the same skills, but on an ambulance, I'm going to have more equipment available. So being in an austere environment means that it's going to affect my evaluation a bit. And I would encourage you guys to have the skills and knowledge to get these non-invasive hemodynamic variables because even in the back of an ambulance, in a critical care ambulance, I have all the equipment that's going to tell me what those variables are very quickly. But in an austere environment, I'm going to have to calculate them, or I'm going to have to think about how to assess this casualty using these skills. And so in an austere low environment, it's going to be a bit different. But what we're using is a mix of two things. One is our general CABC assessment. And we're going to use this, even though this guy was in an auto accident an hour ago, and it's taken him that long to get him extracted and or get him into a three-wheeled tut-tut car to get it to my clinic and my tent clinic. So I need to fall back. I can't just do a clinic-based assessment on this casualty. So I'm going to have to do a mix of both. I'm going to have to do my CABC. So I'm looking at CAT-HEM. So I know it's been an hour since he had his incident. But I need to start at the top. Catastrophic hemorrhage. Catastrophic hemorrhage isn't necessarily going to be just a femur fracture or a limb removal. It could be a broken pelvis or tension hemopneumothorax. So I'm starting at the top, my CABC, and I'm going to stabilize him as best I can with my CABCDEF assessment. And once I've gotten through that, I'm going to roll over, and now I'm going to do the clinic-based assessment, because I've stabilized him with my CABC, but that's still not critical care level. There's questions that we're kind of missing in our CABC. So I need to stabilize him with that, and I'm going to roll over, and I'm going to start looking at my clinic-based assessment. So we have his chief complaint because he was in a rollover auto accident. History of present illness, we know that. It's an hour ago since he had what kind of history of what kind of illness or injury. For the HPI, for this would be injury. So I'm going to find out what precisely was part of that rollover accident. Was he wearing his restraining belt? Were there airbags in his vehicle? Did they deploy? And were there other people in there? Was there a tool chest in the back seat that was flung around, and it's going to cause ballistic problems? So I'm getting a history of this injury. I'm going to have his sampler and vital signs. We'll talk about sampler in a bit. This is the difference between your CABC trauma assessment and critical care. So with critical care, we're going to ask a lot more questions about the casualty history, what this casualty or some of his bunkmates or some of the witnesses can tell us. So the A in chart is all personal, family, and social history. So does this guy have a history of any type of chest problems? Because I'm seeing huge amounts of bruises. Is there a history of cardiac? Does he have a big scar right here that tell me he has had a CABG and he has had cardiac history, but yet he has a steering wheel smashed into his chest as well. So I need this history. Does he have asthma? If I'm having someone with chest trauma and I'm trying to stabilize him and get his C-Pro normal because his capillary refill is way up, his pulse is way up, his oximetry is at 85. So what other history is out there? So I'm trying to get him oxygen on. I've called for evac if I can. That's going to be 8 hours away. So he has a history of asthma. Well, that's going to exacerbate my chest problem at the moment. Is he on blood pressure? Is he on some sort of medicine that makes his heart slow down, a beta blocker or something like that? And if so, why does he still have 125 heart rate? So if without his beta blockers, he's going to have 140, 150. So we need to know this. His history of fever or epilepsy, was he, so we need to get blood glucose, and is he just normal person that because of a low blood glucose made him fall off the road? And so you go through his whole history. And if he's available to answer these questions, we're going to ask him this. And then the review of systems. This is pretty important. And as a city-based paramedic, we'll do a head-to-toe. It's just not the same depth that a full review of systems do. And this is the advantage that docs have when they work pre-hospitally and in remote, because they do this all the time. They do review systems. They can state them off the top of their head, where I have to have my field guide to go through each and every one of them precisely. But get a full review of systems. And I'm going to start at the top, just like a normal head to toe, but I'm going to go a lot more in depth on any type of headache, ears, eyes, nose, and throat injury, or any sleep problems, or change in appetite, or weight gain. And we're looking at a lot of medical aspects to this trauma as well. For chest, there's a whole different chest assessment, and we use an RFLAPS for trauma. So a rate and feel, look, auscultate, percuss, search the skin in the back. For the critical care assessment, we need to go a bit deeper into that. So we're going to look at jugular vein distension. We're going to get central venous pressure measurement off of just the flick of this, the heart rate on his JVD, or if it's not distended, so it might not be JVD. So we're going to do a full cardiovascular assessment as well. We're going to see if there's any tremor on their hands because of CO2 buildup, and going down the GI and GU. We're going to go into much more in depth using this checklist. We have this in our field guide, but we use the same checklist. We just use the checklist that the doctors use, and we go through that to go through our full review of systems. And we might uncover something, a clue or another red flag that we need to address that we would have missed as just a normal paramedic assessment, that we do our head to toe, it didn't pop up, and we think, oh, we're grand, but we're not. So as a critical care practitioner, you need to do your clinic-based assessment and your full review of systems to just have one more tool in your toolbox to see what's wrong with this casualty. And then T in chart is treatment and follow-up. We talk about differential diagnosis. So at the college, if we don't have 5 differential diagnoses, we don't let the delegate go forward. They have to have, there's everything out there, they have to have 5 reasons why this is, such as easy one is belly pain. So this make it easy for a guy has belly pain. What are 5 things? It could be appendicitis, it could be gas, it could be trauma, or it could be food. So we need 5 differential diagnoses on everything. And in a critical casualty, it's no different. You need to have 5 differential diagnoses, even if you know it's sepsis. It's sepsis. I know it's sepsis. The Q-SOFA score is through the roof. I know it's sepsis. You don't want to get blinkered in on what you think it is. By using our differential diagnosis, we're going to keep our peripheral vision out so we don't miss something. So maybe it's not sepsis. Maybe it's malaria. Maybe it's not. So 5 differential diagnoses, and your treatment, your follow-up, and your plan is part of your chart assessment. The overall assessment of a critical casualty for us, we're going to use our CABC. Some people have XABC. X is lots of bleeding out, exsanguating bleeding. Some people use March On, so massive hemorrhage, airway, respiratory, circulation. So we're using CABC. So CABC with our clinic-based assessment is our assessment of a critical casualty. Your secondary vital sign is BEAST. So blood pressure, ECG, alert status, sugar. I know BM is probably the more medical thing, but I couldn't make BM work in the mnemonic, so we said sugar. So S is sugar in the secondary vital sign, and then temperature. Because we work in remote environments, temperature is in everything. If somebody has a temperature, especially in the tropics, I want to know about it, because it's 100% malaria until proven otherwise. And we have to be fastidious on our initial vital signs, so CPRO, and our secondary vital sign, BEAST, because between those two, the primary vital signs, the secondary vital signs, we're going to see these red flags. And temperature in an operational environment is big. It's huge. We need to know there's vast amounts of things that can cause temperature problems. So we need to have your CPRO, which is easy to get. BEAST takes a little while to get, but you need to go through all of those. So assessment of the critical casualty, we're gonna use our 2 vital signs, and we're gonna use urine output. We want to do urinalysis. There's absolutely no reason that you as a medic don't have urinalysis. I have it in 2 different parts of my kit. I have a laboratory lock. It's a OtterBox. It's like that big, and it has a whole bunch of laboratory diagnosis stuff in it. It has an otoscope and ophthalmoscope, and it's got 128 megahertz tuning fork, and it's got just 10 urinalysis dipsticks, and that's going to be in my rucksack. you need this. There's things on that urinalysis, and you need the 10 variables on your urinalysis. So yeah, you can look at sugar. We're not really looking at diabetics at the moment. What I need is protein. So somebody got this person was a rollover on an auto accident, an hour until he gets in your clinic, and you give him a urinalysis. You dip to the urine catch. You're measuring his urine output because you're doing urine catch, and I'm going to do a urine dipstick, and I see proteins. I see blood in his urine, and big red flag, big red flag. I've got some problem, internal problem, and that's going to change my analysis. So, and on top of that, in my clinic kit, in my where my tent is, or if I'm in a hotel room or in a box in the middle of Mali, I'm going to have a huge amount of the urinalysis sticks. But in my personal kit with me at all times, I have 10. And you want to be a good medic, yeah, you'd be good at the basics. We talked about that. So I'm measuring urine output, and there's a reason it's in red. What makes you a critical care practitioner is two things. You're looking at your urine output is one. So if you're monitoring urine output, you're starting to think like a critical care practitioner. The other thing is MAP. We'll talk about mean arterial pressure. Those two things is absolutely gold standard. And our critical care docs who teach for us in the college, and every time they lecture, I'm in the back of the classroom frantically taking notes. I've got, I don't know, 10 or 15 of these things over the years, and I'm just frantically taking notes because I'm learning so much from these guys. They're saying the same thing. They have a wall full of equipment. They've got access to all the specialist doctors in their hospital, and they're looking for two things. They're looking for MAP, and they're looking for urine output, and they have a vast of other stuff they're looking for. But what makes you a critical care practitioner is your knowledge and understanding of two variables. And you can build on that, but the gold standard is urine output and MAP. Good to have is also lactate. We'll talk a little bit about lactate and how that can help. This is your primary vital sign. I can't say how profoundly important it is to have this with you. And you should always have an SpO2 and a spare SpO2. When you work in austere environments, there's a saying that 2 is 1 and 1 is none. And what that means is I have 2 headlamps because I know one of them is going to break. So when I have 2 headlamps, I actually know I only have one. And if I have one headlamp, that's going to break and I have nothing. And I'm using my phone as a torch, trying to get, no, it's just not the way to go. So it's the same with your measurements. So CPRO is so important that you need 2. If you don't have 2, something's seriously problem. So I have my normal pulse ox, but I also have this ECG / pulse ox, so I can get a pulse ox on this as well as my 3-lead ECG, and this one does BP, and it's basically a tricorder. It's absolutely amazing to have just one little bit. A kit does everything. So I have 2 pulse oximeters with me at all times on my person or my computer bag. That doesn't include what's in my backpack. And if I'm working out of a backpack, there's my 3rd pulse oximetry. So 3 is 2 and 2 is 1 and 1 is none. So you can't get CPRO without your pulse oximetry. Yes, you can get CP and R and with nothing. And that's why those 3 are the very first. You can get CP and R with nothing at all. You need your pulse oximetry to get your O. So CPRO is absolutely mandatory. And one trick that we teach at the college is what you see down below is your pulse ox needs to be hitched around your wrist. If your pulse ox is just on your finger like this, when you move the Casualty, you're going to lose it, and guarantee someone's going to stand on this. I don't know how many of these I've lost in my 32 years of being in medicine. That I've lost loads and loads and loads of these, and they get stepped on. So by having this wrapped around my wrist, That means that if this casualty starts thrashing around, this is going to stay with the casualty. Also, someone's not going to nick it. So somebody, if it's just on like this, somebody, when you're not looking, is going to be like, oh, that looks expensive. I'm going to go ahead and take that. So always make sure that you have it wrapped around your wrist so you don't lose cool points by losing one of your two pulse oximetry. This is what you need for your beast, your secondary. A lot of kit, isn't it? So for your BP, you need a stethoscope and you need a BP cuff. These things are pretty amazing. They just go on the wrist, but it's a ballpark figure. As a medical professional, we're not relying on this for anything other than just a quick assessment. I want to get something with my stethoscope and my BP to get a more fastidious, accurate assessment. But these are brilliant for just keeping an eye on the casualty. In fact, we don't let our students use this because it's too easy. We want them to practice. The other things you see here is a thermometer. Now, that thermometer there, I have two. I have one in my, again, two is one and one is none, right? So I have two of them. One is in my personal kit in my computer bag, and the other one is in my rucksack. So, and it always get them without mercury. It is possible to find them. They're a bit more expensive. Get the ones without mercury. The problems with the mercury is when you try to get the whatever liquid's in there, I have no idea what's in there, down, it takes a little longer because I guess the fluid that's there isn't as heavy as mercury. So when you have a glass thermometer with mercury, it's pretty quick to get the mercury down so you can put it in the mouth. This one's a little more of a bother. I don't care. I'm not going to have a mercury device in my backpack or my person as well. It's different. When in the 60s, I remember my parents would have that. If anyone broke a thermometer, they would put it in our hand and we would play around with the mercury. Yeah, we didn't know back then. So don't do that. No mercury at all. And the other thing is your ECG. On the bottom right is one of these that doesn't have a 3-lead. It doesn't come with a 3-lead. You can use a finger and another finger, kind of like this. This does come with leads, which if you're going to buy one of these super small ones, there's loads of them out there. If you have the one that only has like the 2 thumb, don't get that. No. Your QRS wave is going to look shocking. It's just not going to look good at all. So get one of these that has attachment. It goes in here and it's a 3-lead attachment, and you can actually see a lot of stuff in it. So, and the bigger one is the 4-lead, and that's what we have in our trauma bags in the college. We talked about your patient assessment, your CABCs, know the basics, and be really good at your CABC. We go all the way to H. So catastrophic hemorrhage, airway, breathing, circulation, disability, and drugs. Your environment and exposed. F is full set of vitals. G is get documentation, and H is Hitman. So we do this because there's no way for you to forget to roll into prolonged field care. And so after you do your first final assessment, your first full assessment, trauma assessment, you end in H and you just go right into prolonged field care. That's what you got to do. You need to be that strict on starting your prolonged field care. So a quick review on your patient assessment, and I got this from a critical care textbook, so I had to add the catastrophic hemorrhage. They don't include that. They started airway. I'm not okay with that in an austere environment at all. So I put in C in front of their airway. So catastrophic hemorrhage. In this case scenario, this guy had a rollover, and it took an hour for them to get into your tent. If he had catastrophic hemorrhage, he probably died already. But I don't care. I am starting at the very top, and I'm going to look at every body system to make sure there's no other place that he could be catastrophically bleeding. And now we go into where your average critical care doctor is starting. And this is where I'm pulling off the critical care textbooks. So they start with airway. So airway obstruction. They're seeing if there's anything wrong in the upper airway down to where it starts, you get into the lungs. So looking for blood, vomit, foreign bodies, any type of central nervous system that causes the tongue to become flaccid, that the tongue will fall in the back of the throat and start snoring. In an austere environment, maybe you don't have OPA, NPA. So you need to think of positioning. But any infection that can cause airway problems, inflammation, that could be from burns, right? So inhalation burns, you can start having local edema until you just completely cut off the airway, and then you're stuck with your surgical airway option if you're in time. Laryngospasms, swelling due to penetration, blunt, or anaphylaxis or angioedema. That's what they're looking for with the A problem, and have the ability to deal with these A problems. If you're going out on an expedition, or if you're going out on an austere environment where you are the only practitioner, these are things you need to start thinking of. What possible thing could go wrong in the jungle? He could get bit. So we're looking at anaphylaxis. Anaphylaxis is actually one of the most common critical injuries in an austere environment. So what do I need? So think about your, we call it races mnemonic for anaphylaxis, and you know when to give the epi and antihistamines. And so think through what airway problems you might have. And this, as far as the assessment for a critical assessment, they do very similar to what we do as a paramedic. So we're looking at look, listen, and feel. I'm looking for any blueness, or cyanosis, or any respiratory problem, a rate, decrease SpO2. Well, we already have that because we have CPRO, right? So we should have that already. But if you don't have SpO2 on you, then you can look at other ways to clinically see if they are hypoxic. We look at accessory respiratory muscles, if they're in a tripod position. Paradoxical breathing, which means one side's breathing, the other one isn't. Altered level of consciousness. A lot of these go in with breathing as well as airway. Listen, I'm listening for any noisy breathing. I'm going to put my stethoscope right next to the trachea so I can hear any bruits are sounds, French for sounds. And that would indicate some sort of angioedema happening in the throat or any decreased airflow. Here at the college, we have the airway ladder, and it was designed by Dr. Winston DeMello, one of our anestheticists. And it's on page 90 of our second edition field guide. Being a lazy medic, I'm a lazy medic, I'll be honest. If I can do the least amount of work on my airway that works, that sorts the problem, then that's going to be better for the casualty generally. So if I have somebody who's snoring and I do a head tilt chin lift on a non-traumatic casualty, the snoring goes away. Brilliant. I no longer have an airway problem, but I'm going to have to keep an eye on him. So if he repositions his airway, he starts getting a snoring problem again. Happens to a lot of us older guys. You know, I'm in my 50s now, and as you sleep on your back, you relax, and then suddenly you have an airway problem, and you got to sort it. So the easiest way is your head tilt chin lift. But you don't have the time, a lot of the time, to just focus on his airway. So we're going to use an adjunct. So we're the very bottom rung of our ladder is the head tilt chin lift, positioning, or jaw thrust if it's a trauma. Why not use equipment? So you can, the next one up the ladder is the NPA. And the reason that's next is everyone on this planet can take an NPA. In training in the Army, we had to do this. Everyone got the NPA and sometimes both. And then we would have the next lecture with our NPA in, and pretty much you forgot about it. Or how many times have you worked on an ambulance and you're dealing with somebody who has altered mental status due to happy drugs, some recreational drugs? They're losing an airway. You put an NPA in, he wakes up, you give him Narcan. He wakes up, he runs off. He's got this big pipe in his nose. He doesn't even know it. He's going to wake up somebody some morning somewhere. He's got like, what is this? What? So everyone can get an NPA. It's actually pretty benign. Now, if you have septal deviation or big concha, things like that, you can't. But It's brilliant. It's safe enough. Everyone can get one of those. If you try that and it doesn't work, you can go up the ladder, which is your OPA. But in all honesty, I'm a lazy medic. I'm not going to carry an OPA because I'm going to carry an iGel. I'm going to carry a King LT. I'm going to carry an LMA. Well, I don't like the LMAs as much, but the iGel is amazing. In fact, in Ireland, my home country of Ireland, they're giving iGels to somebody with 6 hours of medical training. They get CPR training and they get this iGel, and they're like, you know what? Just shove it in the gob. You can't mess it up. Just go. It's safe enough. Just, if they're dead anyway, you're doing compressions on them. Why not just throw an iGel in, and it can't go too far. It's brilliant. It really is a good bit of kit. If the iGel, so that's a supraglottic because it doesn't go through the vocal cords. The vocal cords, anytime a pipe goes through the vocal cords, that means it's an intubation. It's a definitive airway. So your supraglottics, your iGel would be my number one choice. Your King LT would be another one. LMA, and the reason we teach that at the college is because they're $3. And in lots of places that you're working in an austere environment, you're working for a mining company that just wants to save money, and they say, all right, what do we need for our clinic? We need a supraglottic. All right, what's the cheapest? LMA. Okay, there you go. Could do an LMA because iGels, they're 10 quid. Why would I buy an iGel and I can get an LMA for €3? So I personally am carrying an iGel, but an LMA may be the only one. And LMAs are finicky. You have to partially inflate it. You got to know how to hold it like a pencil and go in. And so we still teach it because people are getting it. King LTs are brilliant as well. It has two balloons that seem to do pretty well with blocking the upper and lower airway. It's kind of hard to screw up the King LT. When I started in the 80s, and I think we had the combi tube. No, that came in the 90s. In the 80s, we had nothing except ET, and I was an EMT back then. I wasn't allowed to intubate, but I remember when the combi tubes came out, and combi tubes are basically these two very big tubes, and you just kind of throw it down the throat and hope for the best. No, we don't teach that anymore. No, and they're 30 quid, so we're not seeing them in Africa or Asia or anywhere we're working because no one can afford them. So we don't talk about the combi tubes at all. So if you do your positioning and it doesn't work, your nasal pharyngeal airway, it doesn't work, we're going to skip the OPA because I know our anesthetic docs in the college who's probably listening to this right now. They're like, we use them all the time. Well, I have to carry my own equipment, so I'm not going to carry an OPA. I'll carry an iGel. So if the OPA doesn't work, if the supraglottic doesn't work, then we need to start looking at intubation. And intubation, we're looking at, hopefully he's a dead guy already. Like most of the intubations I've ever done in my life are dead people. They're cardiac, and we're doing compressions for, we got time finally to stabilize and put the tube in, and that's fine. RSIs, you're intubating a person that's alive, and it's a lot risky. As a critical care paramedic, we do that a lot, but there's a lot of variables. In an austere environment, we're starting to teach to skip the intubation rung of the ladder and go straight to the surgical airway. Now, we have some docs on our faculty who don't like that, and I agree with them. A surgical airway is an extremely invasive procedure, but it's kind of the only way to get there's a higher percentage chance of being successful with a surgical airway than an ET tube. No, I'm better than 50-50. I don't know. In my whole life, I'm saying probably 65% success rate with my ET tube. You know what? I'm not the best, and I don't do it that much anymore at all because I'm more into the research side of things. So if I was in an austere environment and I had somebody who I walked up the airway ladder. I started with position, didn't work. He still wasn't ventilating, oxygenating. NPA doesn't work. Supraglottic doesn't work. And I'm looking at ET tube. I have an ET tube in my hand, and I have a surgical airway in my hand. I know that I'm going to be more successful getting a definitive airway with a surgical airway. So if I have the scope of practice in the country I'm working, because my ability to do an surgical airway, doesn't mean I'm allowed to do a surgical airway. I have to have the scope of practice, the right a practice. So if I'm allowed to do the surgical airway, I would choose the surgical airway over an ET in an austere environment, because a higher success rate, and I don't have to paralyze the lungs. So with a surgical airway, you can have someone completely alert and oriented times 4, GCS of 15 with a surgical airway in, and he's fine. He's fine. I don't have to paralyze him. So it depends on your scope of practice, but as a critical care practitioner, I would encourage you to have the experience and skill to work with a surgical airway. The inflation on, so when you evac someone and you are going up in altitude, that's correct. The air in the bulb of your ET tube or your surgical airway tube has a chance to deflate. So iGels, you don't have to worry about that at all because there's nothing to inflate. Same with King LT does have inflation, so you got to worry about that. But because you're a critical care paramedic or a critical care practitioner, you're really good at what you do. You're going to have BP cuff, and you can use your BP cuff to test the air in your balloon to make sure that it's 15 millimeters of mercury. Anything more than that is going to cause ischemia. Anything less than that is going to slip in and out. So as a critical care paramedic, if I'm working on a flight, I'm going to check all my tubes with my BP kit to make sure that my tubes aren't going to deflate. That's a very good point. Now we're looking at breathing. Look, listen, and feel. So I'm looking at altered respiratory rates or decrease in my CPRO, my SpO2, or any blueness, cyanosis, altered level of consciousness. I'm looking for all of these to see if I have a compromised breathing problem. Looking to listen. If I don't have a stethoscope, I was born with a stethoscope right here. The French designed the stethoscope because they didn't want to touch people. And I got friends who are French. I'm not saying that they're that way, but the guy who invented the stethoscope didn't want to put his chest on the bosom of some lady. You can listen. You can hear breath sounds with your ear. Put it right on the chest. You can hear it just as well as you can with some of these crappy stethoscopes. Now, my Littmann 2 stethoscope is much better, of course, but I mean, if I have nothing, why not? There's no reason why you can't listen unless it's too loud in the area. But I'm going to listen for crackles, rails, dullness to percussion. I'm going to feel for symmetry, chest movements, position of the trachea. So these are all lists from the critical care textbook. We've already done this under our R-flaps in our breathing assessment, but that's just, I prefer the R-flaps way of doing things. Treatment. If any breathing problem, we can give supplemental oxygen. We don't always have that in a remote environment. Pursed breathing is going to give you PEEP. Now, pursed breathing is not going to give you a lot of PEEP, but you know what? It's going to give you PEEP. So this is something I put it in red on for a reason. You need to have this as a pretty quick go-to for breathing problems. So are you going to get an asthmatic to pursed breathe? Probably not, because they have the look of doom. They're tripod. They have a difficulty getting a breath anyway. Asking them to pursed breathe, you're not gonna get them to do that. But if you can get somebody with breathing problems to pursed breathe, that's going to give them a little bit of PEEP. Is it 5 millimeters of water? Don't know. There's no research out there, but you know it's PEEP. We might need to look at give him analgesia if he has any chest wall injuries, because the pain is causing him to be tachypnic. So if we relieve the pain, he'll start breathing normally, and they're going to be in a position of comfort regardless of what you're trying to do. So trying to get an asthmatic person out of the tripod position, you're never going to have that happen. He's going to stay there. And you provide ventilatory support. In a critical care situation, we're looking for circulation problems, tachycardia, bradycardia, hypotension, pulse pressure. We're going to talk about pulse pressure a bit next lesson. I'm going to listen for my heart sounds. I'm going to listen for bruit in the carotid, and especially if I'm going to put an ET tube in, I'm going to listen for bruit there as well. I'm going to feel for all the different pulses that I have and compare them right and left. Maybe one's different. Maybe the pulses go away when you breathe in. So there's variables that you can find by getting your systemic pulses. A quick overview of your pulse pressure. Pulse pressure is the difference between your systolic and diastolic. And a narrow pulse pressure means you're going to have some sort of cardiogenic problem. A wide pulse pressure, so your systolic could be staying up high, but your diastolic is dropping like a rock. You could be in some types of shock. So we'll talk a bit more about pulse pressure in the next lecture. Circulation. We're looking at fluid resus or blood resus. If blood came out of the body, that's what we're putting back into the body. If water came out of the body, that's what we're putting back into the body. So there's a minimum, better, best for hydration. The minimum is oral. And we talked in the last lecture about everyone drinks and why it's not always good practice to keep people from not drinking. You can hydrate. You can completely resus yourself orally. You can drink enough water orally to have a full resuscitation. The maximum amount of water that you can drink in a 1 hour period is 1 liter. Anything over 1 liter, you're going to drink it, but you're going to pee it out before your body can really use it. So when you're talking about minimum oral rehydration, minimum requirement for fluid resus and orally, you want to drink 1 liter, but you want to drink it over an hour. You don't want to drink it all at once. So the Camelbacks are brilliant. So have a sip of Camelback, or your Casualty. Have your Casualty just continually sipping on a Camelback or something just to get that hydration. Better option would be IO hydration, or the best would be IV hydration. In other lectures, we talk about rectal rehydration and dermoclysis rehydration, which is still being used successfully with good research behind it, but that's another lecture. Point of care testing and ultrasound can quickly give you an idea of your hydration status. So D is disability, and we also say D for drugs at the college. So this is where you're going to start if you've forgotten up to this point on getting pain management, or if they feel queasy, you can give them ondansetron or something to deal with queasiness, pain, or any type of drug that they need up to this point. You need to do it at least by D. D disability is pain scale. We're going to look at blood glucose. If you don't have it by this point, you should have, but if you forgot it, you're going to do a GCS or A&O times 4, and we'll splint and immobilize fractures. In a city-based paramedic system, we're doing a head-to-toe at this point. We don't do a head-to-toe until we go through the full prolonged field care. And then once we get into the chart, we do a full head-to-toe there. This is pretty important. I have stepped on more hands than I care to admit. We're kneeling on the ground and we're dealing with a casualty, and they're rolling, and we're getting, because we're good medics, we're getting a blanket under them, we're getting in a hypothermia wrap, and their arms are flailing all over the place. The pulse oximeter is still there because you've wrapped it, but now it's off and you're kneeling on it. And so if somebody is unresponsive or pain responsive, you need to tie their wrists together. Now, I'm not going to tie them tightly. You need to tie them with a bit of space, because as they come in and out of consciousness, they want to touch, they get itchy nose, or they get in. So in all fairness, any alert status, you can do this if they allow you to. You can just explain it to them. This is for your own good. We don't want to kneel on your hands. So everyone gets to bind the wrists together. And you can do it in a way that, if they freak out, you just pull themselves out, which is fine. But I'm done kneeling on my patient's hands. I've done it far too many times, couldn't even count. And that's it. We don't do that anymore. So make sure they tie the hands together. E as environment or expose. In a critical care textbook, they don't really talk about environment because they're in hospital. But expose, they want to means that they look at everything that's wrong with this casualty. Look at the legs. Is there pitting edema? Or is the bottom parts of the legs cold and the tops of the legs not cold? That tells me a lot as a critical care practitioner on the shunting and the shock status of the casualty. But at this point, as a austere environment practitioner, you need to look at the environment and expose and keep this casualty normothermic. You don't want them too hot. You don't want them too cold. That's just basic paramedic science. F. So this is no longer the critical care patient scenario. This is our college's patient scenario. Once you're done with D&E, you go to F. You get a full set of vital signs. And we have our primary vital signs and secondary vital signs. I don't care if you've done it already. Do them again. We talked about the two things that make you starting on the pathway of thinking as a critical care practitioner. One is urine output, and the other is MAP. You need those two. The third one is trending. Trending is longitudinal observations, where you're looking at your primary and secondary vital signs every 5 minutes, every 10 minutes, and start seeing a trending. That is going to be a huge help for you. And we write this on the wall. We have our college, we have the prolonged field care sheets that are like A0 size, which is like half of a wall. And we just write in everything we write in because we're looking for trending. So F, full set of vital signs, and get it again, and then make sure you document. G is get documentation, and I'm looking for trending. Now we have three things that make you a good practitioner in austere environments: urine output, MAP, knowing where your MAP is, and trending. And after you're done with G, we go into H as a hitman. This is not a prolonged field care lecture. We're assuming you already have had prolonged field care. If you want to take our advanced prolonged field care lesson, we've got 2 webinars coming up that are going to discuss some advanced topics in PFC. That's a different one. So bottom line is we have an austere critical care casualty, and we need to be really good at assessing them. We need to have our normal CAVC paramedic assessment. And when you're done with that, you move into the doctor level stuff and the clinic-based assessment. So page 6 and page 24, both of those pages, you start with page 6, you stop them from dying on you, and then you move on to 24, and now you're talking about critical care. This is the page 24 of the chart assessment, or the SOAP is very similar to this. I think the Americans use the SOAP, always confused me. So chief complaint, history of present illness or history of present injury. We're looking at sampler. A is all patient history. And this is where you're getting a history from the casualty. We're asking them a lot more deeper questions than we do as you're thinking as an EMS or paramedic practitioner. R in chart is review of systems. We're doing full head to toe, but we're doing a doctor level review of systems. And we have 8 pages in our field guide where each system is discussed. And then T in chart is treatment, follow-up, differential diagnosis. Main points to remember with assessment: detailed history. 85% of your diagnosis is going to come from the patient's history or a history of their spouse or their bunkmate. So get as much history from them as you can. The core principle of managing critical illness is to treat the cause and provide specific resus for the injury, the insult, original insult, and frequent clinical monitoring. But here's the main points. There's 3 things that you need to start looking at. Urine output on hourly urine output. You don't just want to say, well, they just peed out 850 mils, brilliant. We're talking about trending. That's the third one. So we're talking a long-term assessment. So urine output, mean arterial pressure, trending. So this is what these 3 things are, the golden rule. So we're going to look for early signs, like a drop in mental status, drop in urine output, drop in peripheral circulation, which means here is cold, here is warm, big warning sign, big warning sign. Something is going wrong. So a drop in peripheral circulation, vital sign change, either going up or going down. And you're only going to see this with trending. If you do a CPRO primary assessment, you're like, all right, well, it's 125 pulse rate. That's fine. He should be good. No, because 10 minutes ago, he had 85. So unless you do your trending, you're not going to see a big red warning sign of this guy going 85, 88, 90, 92. Every 5 minutes, it's like, okay, now he's 100. And if you just look at that, oh, he's got a pulse rate of 100, he's grand. He's not, because of trending. So you need these three things to be a good practitioner. Yeah, I've hit that pretty hard, haven't I? So those three things: longitudinal observation, a good history. This is Sir William Osler. He's the one that came up with 85% of your diagnosis is going to be a history. 15% is going to be the rest of the stuff you can do. So you want to be a good critical care practitioner anywhere on the planet. You need to listen to your casualty. That's 85% of your success rate. And differential diagnosis. That's an T in chart is also differential diagnosis. Always find at least 5 things wrong with your casualty. If you can't find 5 things wrong, think again. You don't pass an assessment at our college unless you do your 5 differential diagnoses. I don't know if I said this again. 3 things. You got to know these very, very well.